Welcome to a brand new episode of our academic program on obesity management hosted by Plexus and Center for Metabolic Surgery. Headed by Dr. Raman Goyal, Center for Metabolic Surgery is among India's top bariatric surgery centers. CMS represents a comprehensive team of surgeons, physicians, dietitians, and psychologists to assist on weight loss surgeries. So every Thursday, same time, we host clinical discussions around obesity management. This program will include an expert opinion from our guest speaker, along with a patient testimonial and experience sharing about the treatment. So today we shall be discussing about obesity management in children. The high prevalence of childhood and adolescent obesity, coupled with short-term and potential long-term health implications, has emphasized the need for obesity-related clinical services, including assessment, treatment, and preventive care for patients, for children and adolescents. So pediatric obesity is one of the most pressing health problems facing children and adolescents today. So to throw some light on the same, we have our guest speaker for today, Dr. Priti, childhood obesity specialist, pioneer and exclusively practicing childhood obesity since 2006. She is the National Fellow of SCOPE, that is Strategic Center for Obesity Professional Education of the World Obesity Federation as well. Priti is the task force member to fight against non-communicable disease like obesity, diabetes, and cancer in the Maharashtra government. Dr. Priti is also the vice president of AIAARO, that is the All India Association of Advanced Research in Obesity, the Maharashtra chapter. She has won a lot of awards, two of which I would like to mention specifically, which is she's won the Best Poster Award at the Asia Oceanic Conference on Obesity and Malaysian Association for the Study of Obesity Scientific Conference 2021, and for paper presentations on childhood obesity at the All India Association of Advanced Research in Obesity in MahaCon 2010, 2009, and 2009 as well. She is also authored in various publications in index and non-index journals. So without further ado, let's start today's proceedings. Welcome, Dr. Priti, to Doc Plexus.
Thank you so much. Thank you.
So, ma'am, I would request you to share your screen and if you could start your presentation.
Is my screen visible?
Yes, ma'am.
Yeah. Can I go ahead?
Yes, ma'am.
Yeah. Thank you, Darshika, for your kind words. Good evening, one and all. It's my proud privilege to be here amongst all of you. Thanks, Dr. Goyal sir, for this opportunity, and thanks, Doc Plexus, for this wonderful evening session. Today, I'm going to talk on managing obesity in children. As rightly said, Darshika, it is the growing problem which we are facing. World Health Organization in 2018 stated that India was at second position globally for the childhood and adolescents obesity. And in March 2020, India was the first country to declare the lockdown to reduce the burden on healthcare system, which has unlocked the weight from pediatric to geriatric population. Though children, they have the less directly affected by the virus, they are paying heavy price through the indirect effect of the crisis, including inadequate nutrition with risk of both overweight as well as underweight, reduced activity, social isolation, mental health impact, addiction to screens, and lack of schooling and healthcare, particularly amongst the vulnerable groups. So in 2020, World Health Organization has stated that about 37% of adults and 14% of children worldwide are overweight. Worldwide, the rise in obesity has been fueled by the COVID-19 enforced lockdown, and because of which the newly developed term Obesity has been introduced to portray the aggravation in obesity. Today's topic is managing the obesity in children. But unless and until we don't know what is the pathophysiology, what is the burden globally, what is the burden nationally, we cannot go ahead. At present, what we are seeing only the tip of icebergs. and what the next picture will be, it is really worrisome. Before proceeding for the management should be of the condition who has been declared as a disease. So let us discuss, is obesity is a disease? Yes, definitely. A very comprehensive definition given by the Obesity Medicine Association in 2020, as it is, obesity is a chronic relapsing multifactorial neurobehavioral disease wherein an increase in body fat promotes adipose tissue dysfunction and abnormal fat mass, physical forces resulting into metabolic, biochemical, psychosocial health consequences. And it has been declared as a disease by the American Medical Association in 2013, by World Health Organization, World Obesity Federation, Canadian Medical Association, and so on. But we, Indian government, not yet. So this is again an impact of obesity as a disease in form of endocrine, immune response, physical response, psychological response, as we all know, very well aware about all these responses. So World Obesity Federation states that the roots of obesity runs deep. It may be in form of biology, food, genetic risk, healthcare access, life events, marketing, mental health, sleep, and stigma. So many of the times patient used to say that my parents are obese, that's the thing, I'm obese. No doubt genes plays a role, but genes are responsible only for the 40%, environment is responsible for the 60%. A child with one obese parent has a 50% chance of being obese. When both parents are obese, the children have an 80% chance of obesity. That's the thing. The dictum is there, obesity runs in family as nobody runs in family. So here definitely we can understand the importance of environmental modifications, though the genes are there. More than 90% of cases are multifactorial, less than 10% are associated with hormonal or genetic causes. What are the critical periods for the childhood obesity? Let us start from the preconception. Preconception, pregnancy, infancy, adiposity rebound age, that is between 5 to 7 years, and adolescence. The management aspect should ideally start from the history. What points to be covered in history? First, antenatal history. Was there excessive weight gain, gestational diabetes mellitus, pregnancy-induced hypertension, thyroid disorders to the mother, birth weight, onset, whether it was in infancy, childhood, duration, rapidity, developmental history, drug history, dietary and physical activity history, screen time, sleep cycle, and all these will be the drivers of obesity. And what are the complications of obesity by which we can understand? That is dyspnea on exertion, sluggishness, day drowsiness, snoring, chronic anovulatory cycles with or without hirsutism, polyuria, polydipsia, polyphagia, knee or hip pain. That all about the comorbidities of obesity. Extremes of birth weight are the forerunners for the childhood obesity. Medications, I will not go in the detail because as we all aware, cortisol, appetite stimulating, tricyclic, antidepressants, and so on. This baby is a drug-induced Cushing, resulting into obesity. By seeing the baby, one can immediately note down that this is a drug-induced Cushing, resulting into obesity. So this is again start from the infancy. We have to take a history in detail. We have to take a history in form of feeding pattern, in form of weaning. That again will clinches the diagnosis and will be able to manage the patients very well. Screen time and sleep, definitely increased screen time resulted into insomnia, symptoms of depression. Electronic devices are emitting an artificial blue light which used to suppress the release of melatonin hormone, which induces the sleep. The more time teens spends in front of an electronic devices, especially in the evening, the greater the delay in release of melatonin, making sleep as a challenge. How the sleep deprivations resulted into obesity? Sleep deprivation causes boost in ghrelin, which stimulates the hunger, reduction in leptin, a hormone that makes us feel satisfied, Sleep deprivation causes craving for high fat, high calorie foods. The concept of fourth meal comes from the teens staying up later than they should and getting hungry. The less sleep we get, the less energy we have to go to the gym. And all this affects our metabolism, resulting slowdown of our metabolism, burning fewer calories on daily basis. And all this thing causes aggravation of obesity. Especially adolescence is a very critical period for the development of obesity, and adolescence obesity is nowadays fastly growing obesity. The adolescence years are very characteristics of changes in the body composition, because adolescence, that is a pivotal phase, and pregnancy, these are the two physiological phases of life where the insulin secretions is more. That is called the physiological insulin resistance phase. Physical fitness, decreased insulin sensitivity during the puberty. This period of growth and maturation also marked with the behavioral changes in the diet, physical activity, sedentary behavior, and psychosocial health. So all these things ultimately making adolescents a risky candidate for developing the obesity as well as rapidly progressing the obesity also. This is a boy, just today I saw this boy. In the 10th standard, mother gave the history, boy was weighing 72 kg. In 12th standard, the boy was 82. That is on February 2021, and on 16th September 2021, today, when she brought to me, boy was weighing 92 kg. That speaks of adolescence is a very critical phase for rapidly developing obesity, as well as the having that comorbidities also of obesity. So who are the risky candidates for the obesity? Especially children of kirana stores, hotels, restaurants, food mall, children of literate family, affluent family, even daily wages children are the victims for the obesity. It is really surprising, but nowadays these children are also getting obesity, single issue, single parent, chronic illnesses, mentally challenging baby, and all these things. Another 90%, as I previously said, that multifactorial 10% will be of endocrine obesity or the genetic obesity. Endocrine obesity, hypothyroidism, glucocorticoid excess, that is Cushing syndrome, growth hormone deficiency, pseudohypoparathyroidism, and leptin deficiency. Genetic syndromes which are associated with childhood obesity are the Prader-Willi, Lawrence-Moon-Bardet-Biedl syndrome, Cohen's, and all these things. So as soon as we used to see this baby, definitely severe infantile obesity, one should suspect the leptin deficiency. And these are the children who land up with the severe infantile obesity. How to tackle the obesity? Canadian Obesity Association has said 5 A's are very important for tackling the obesity. First, we must ask the permission to discuss the weight, especially to the adolescent. Many of the times, parents forcefully used to bring the children for their weight management. But on the contrary, children are not ready to discuss their weight, not ready even to change their lifestyle or change their behavior pattern also. So the management's first important milestone is we should ask about the permission. Then assess permission to discuss the weight. We can assess in form of the BMI, that is whether the child is in overweight category or obese category or in morbid obese category, and one can assess on the clinical examination also. Third one is one can advise the health risk of obesity with the children as well as adolescents. Benefits of modest weight loss, that is 5 to 10% also. Agree, and they should be agree on the realistic weight expectations. We can go one by one. So first and foremost thing is how to approach the obese or overweight children and adolescents. First part, we have already deal with that history. Now we can proceed for the clinical examination. On clinical examination, after having that anthropometric measurements in form of weight, height, BMI centile, waist circumference, BP measurement, one can also see for the signs of insulin resistance in form of acanthosis nigricans, skin tags, mooning of face. Neck examination is very, very important. Just to put a thumb on the neck region front aspects to see whether the child is having goiter or not, to palpate If there is a thyroid nodule, one can ask for the history of menarche, menstrual history. Is there any signs of hyperandrogenism? One could look into the matter. In case of boys, one can see the lipomastia or the gynecolipomastria, sexual maturity rate, and dysmorphic features. These are the growth charts. These are by the WHO for 0 to 5 years, and these are the revised Indian Academy of Pediatrics from 5 to 18 years. This is a modified, that is a pediatrician friendly growth charts. I can say that for any doctors can use these charts very well, because there is no calculation of BMI, no calculation of MPH, and which can save the time also, and one can easily mark out whether the child is in overweight category or obese category by looking into the graph. Pink is for the girl and blue is for the boys. This is a flow diagram which I used to follow in my clinic. Whenever the patient of childhood obesity comes, one should have that anthropometric measures meant to be studied thoroughly. If the child is of normal stature, all the tall stature, one can suspect the nutritional or exogenous obesity. If the child is short stature, one can expect either it is an endocrine or the genetic obesity. One should not forget to take the waist circumference also, because Indian ethnicity is known for the central obesity and children are not exception for this. These are the waist circumference cutoffs for the metabolic syndromes screening risk factors in boys and girls. This one can very well make out. These are the acanthosis nigricans. Many of the times, children are brought for the other problems, not directly for the obesity. This girl is brought for the premature thelarchy, and on examination, she was found obese with the sexual maturity rate of breast development in second stage. So on investigation, she found to have the pre-diabetes. So this is the thing, one should have the clinical examination thoroughly. Many of the times, boys are used to bring for the pseudomicropenis. This is the boy who brought for the gynecolipomastia. So many of the time, obesity is been not considered very seriously even by the parents also. They used to think that these are the problems which can be tackled differently. But whenever I used to say that this is for the root cause is obesity, then they can understand properly. Many of the times, the adolescent girls are used to brought for the PCOS, that is irregular menses, scanty heavy menses, acne, hirsutism. So is history part. After the history part, clinical examination is also very important before reaching the management. So obese but short, definitely one can think of genetic or hormonal. This is the girl who is 9 years and she is standing beside her 3 years old brother. One can clearly make out that she is short for age and she found to be hypothyroid on investigations. So why we are discussing about the childhood obesity? Because there are the health risks of the obesity, and obesity, it is the mother of so many diseases. Obesity can lead to high blood pressure, high cholesterol. It can lead to impaired glucose tolerance, breathing problems such as asthma, sleep apnea, joint problems, fatty liver disease, gallstones. As well as obesity is a very important factor for the psychological problems also, such as anxiety, depression, so low self-esteem, lower self-reported quality of life, social problems such as bullying and stigma. So after considering all the health risks, there is definitely need of managing the childhood obesity to prevent all the consequences. What are the future risks? Because many of the time, children with obesity, these are the forerunners for the adult obesity. Adult obesity is associated with increased risk for several serious health conditions, including heart diseases, type 2 diabetes, and cancers. So this is the thing, why one should be very keen on managing the childhood obesity in time. Because if we don't tackle the childhood obesity in time, definitely there is a high chances of tracking this childhood obesity into the adult obesity. More they approaches towards the 18 years of age, more are the chances of tracking into the adult obesity. So these are the comorbidities of my own institute data. Definitely, my center is a tertiary referral center. So one can think of these are the high figures. Out of that total group, I found that 43% were normotensive as against 33.9 were prehypertensive and 23% were hypertensive. And this is the data one can look into the matter that why one should be very serious about managing the childhood obesity in time. This is, I studied the data in form of pre-diabetes, diabetes. 31.8% were found to have the normal A1C as against 64.3 were found to have the pre-diabetes. And this is the percentage where we can really make the difference in children's life. Once we diagnose early the childhood obesity and manage efficiently, we can prevent definitely the consequences in form of prehypertension, hypertension, pre-diabetes, diabetes also. This is the youngest girl, 4 years old girl. Father, mother, both are obese, and she found to have the pre-diabetes. So the total percentage which has been stated that 10% of children with obesity they found to be pre-diabetes, and this is really an eye-opening for all of us. If we treat the obesity early in time, definitely we can prevent all these consequences. So after taking the history, after doing the clinical examinations, and now one should proceed for the workup. What are the routine investigations for the children with obesity? In form of hemogram, blood sugars, either it may be random or fasting. Nowadays, fasting serum insulin is not recommended at all. Thyroid stimulation hormone or whole TFT whenever there is in form of family history of thyroid disorders, or whenever there is a thyroid goiter, we can go for the anti-TPO antibodies also, lipid profile, OTPT, because nowadays more and more children I am seeing with derangement of OTPT. A1C, vitamin D also, because obesity is one of the important risk factors for the vitamin D deficiency. What are the specific tests? Specific tests in form of 2 hours post-glucose, GTT, C-peptide, whenever there is a raise in A1C. Puberty problems, we can go for the FSH, prolactin, E2 test, depending upon the underlying features. Endocrine obesity, one should do cortisol, serum cortisol growth hormone, depending upon the underlying features. Even liver fiber scan, especially for the adolescents with morbid obesity, in case of deranged OTPT. Sleep study, whenever we got the history of obstructive sleep apnea. Gene sequencing for the genetic obesity. This year's World Obesity Day dictum was everybody needs everybody. Now we came to the diagnosis of obesity, either it is a nutritional or the endocrine or the genetic, after taking history, doing clinical examination, investigations. Now we can manage the patients accordingly. Obesity management is a needs multidisciplinary approach. What should be the management goals? One should have the proper management goals, especially in case of childhood obesity, because childhood obesity is different from the adult obesity, because that is a very sensitive age for the growth and development also. So the management goal should be healthy habits, to develop a healthy habits and lifestyle patterns which can remain throughout the adulthood, improve the health and quality of life, improve the body composition, prevent future adverse health consequences, as well as improve the body image and self-esteem, which is very important. These are the guidelines for managing obesity given by the Obesity Medicine Associations. First, we have to have the proper sleep pattern, no TV in bedrooms, proper adequacy of sleep, all meals at the table or high chair. Parents should be as a role model for the children. Food should not be used as a reward. Parents should not be over controlling, and many times the children are really get frustrated because of the over controlling of parents. Family-based therapy, active play almost constantly, minimal sedentary life, 3 meals plus snacks is very important, and 3 servings of protein, 3 servings of non-starchy vegetables, fruits, because many of the children, they are very fuzzy in eating. Many of the children, they use the maximum time, either they use the potato, ladyfinger and all these things. They even know the other vegetables also. So we should train the children to eat all the vegetables, all the fruits, so that they can get the adequate nutrients amongst that. So this is a healthy eating plate, and one should be have proper fruits, vegetables, protein, grains, dairy products. Many of the times the parents used to say that as the children are putting on weight, the first thing used to stop that is a milk and milk product. But that is a very wrong concept. One should have the dairy products, because girls between 8 to 13 years and boys between 9 to 14 years, they will deposit 50% of their whole calcium requirement during this period. So dairy products, but one should give it low fat. Low fat milk can be given. So no dieting concepts in managing childhood obesity, but definitely diet modification plays a great role, should be followed at the family level, not at the individual level. Restricted food steps should be avoided. Many of the times, children's needs variety, attractive and tasty foods. Though the foodstuffs we want to give, that can be used, but there should be variety, attractive, tasty. Family members, teachers, school authorities should be aware of the healthy food also. School should give the food planner to incorporate the healthy dietary habits to fulfill the nutritional requirement by the experts' nutritional advice. So who is going to change? Many of the time, once the obesity sets in children, many of the times parents think that who is going to change? Either mother, father, or whole family. Definitely, family level changes will make huge difference in children's life. Many of the time, other family members used to think that the weight loss diet may be tasteless, costly affair, time consuming to cook. But one should address these concerns also while doing the counseling of the family. Children don't eat properly, remain hungry, which will add to their irritation if we have a weight loss diet, but that's not so. Weight loss diet is definitely one can make tasty, attractive, as well as we can have that proper nutritive value also. Nobody wants to share the tiffin, will tease regarding the tiffin content. Many of the children, they have the main concerns regarding this. Celebration of festivals and hospitality of guests cause frequent cooking of calorie-dense foods in family. And many of the times, because being India is the festive season, cultural background, many of the times we used to cook the very high calorie dense foods on the occasion of feasts. One should avoid definitely this. So dietary modification definitely can cause a huge difference in children's life. I can share this example. This is a boy of 8.9 years. On examination, he was having A1C 7.3%, urine ketone negative, and C-peptide normal. So we counseled the family properly. The patient followed up very regularly. And after 15 months, we found that the child was initially having BMI 27.5, reduced to 21.7 with normal A1C. And this is the magic of lifestyle modification at the family level, which can result into the clinical reversal of type 2 diabetes. As early we started the changes in children's life, they are more customized and they are produce better results in children's life. So nowadays, the concept of intermittent fasting is coming, or time restricted feeding. But what the pediatric obesity algorithm by the Obesity Medicine Association states about this? Intermittent fasting means 5 days on, 2 days off, alternate days fasting, eating for 6 hours and fasting for 18 hours, which is very difficult for the adolescents. Some study shows consumption is greater on fasting days than the planned and less on non-fasting days, which can happen with us also many times. Most studies shows poor adherence, not enough research in children to recommend this, may lead to disorders eating, and not a great option for those with binge eating disorders or depression. So no fat diets. So I want to say that in era of Wi-Fi means without internet family interactions, which really helps a lot, not only to the children, but to the whole family also. Activity recommendations, either in form of aerobic, endurance, bone building, muscle strengthening, active play, These are for the various age group, but one can remember that the activity should be enjoyed by the children. It is not being forced on the children. Children should enjoy the activity. Drug therapy has a very limited role. Orlistat can be recommended after the age of 12 years. We can minimize the obesogenic medications, especially for the small for gestational age babies. Treat asthma with control medications to minimize the systemic steroid use. Metformin by FDA, it is approved for the type 2 diabetes children above the age of 10 years. So once the obesity sets, it is very challenging for the child, for the family, for the society, and ultimately for the nation also. So prevention is better than cure. To prevent obesity, we can act at the level of child, family, school, health providers, professionals, and community. And that's the thing. I really want to acknowledge and appreciate Dr. Raman Goyal sir and the Doc Plexus team for taking this initiative. So what are the take-home message? The problem of childhood obesity is global, steadily affecting many low and middle income countries, particularly in urban settings. The prevalence has increased at an alarming age. India is facing the double burden, and obesity is not a disorder, but is a disease, chronic, relapsing, multifactorial. Pediatrician friendly growth charts are available, which are less time consuming. No need to calculate the BMI, no need to calculate the mid-parental height. BP measurement is must in each and every obese kid. Every obese kid should be investigated. Family counseling is the key for management of childhood obesity. Comorbidities can occur both in overweight as well as in obese group. Early detection and action can cause clinical reversal of diabetes, type 2 diabetes in obese children. So alone we are smart, but together we are brilliant. So we are here. The wish is hard, dream is big. Together we can make it happen. Thank you for the patience listening.
Thank you so much, Dr. Priti. Wonderful presentation, and I am sure our fellow pediatricians on the platform would definitely greatly benefit from the same. We have a couple of questions for you.
Yes.
So our first question is from Dr. Agastya, who says, what measures should be taken for the social and psychological development of obese children?
Okay, that is very good questions. We have already implemented this at our institute. So these children should be brought at the social platform. So for this, we have organized an energy health club. On the same platform, we used to call all obese children, and we used to conduct 1 hour physical activity as well as 1 hour intellectual activity, so that they can gain the confidence and they can see the children around them. They are of same obesity category and all these things. Many of the children, they think that once obesity sets in, I'm not good enough, or I'm having very less confidence, I cannot mix with my friends. So this social stigmatization can be minimized by bringing them at one social platform and boosting up their confidence by their likely activities.
Sure, ma'am. Ma'am, another thing that we would want to know is, when it comes to children, what is the biggest complication that you face when dealing with children as a physician?
Regarding that, in which age children are presenting to you with obesity, that is really matters.
Okay.
Because the girls are presenting with obesity with an early puberty, early development of breast, early menarche, and because of which they have the very low self-esteem, decreased height velocity, and all these things. And at the adolescent age, once they present in an adolescent age, they are the very crucial age group for their career development also. So they will lag behind in their curricular activities. They will not mix. They will go in depression, anxiety, nervousness, and all these things.
Sure, ma'am. Thank you so much, ma'am. I think these were all the questions that we had. Dr. Goyal, would you want to? I would just now introduce Dr. Raman Goyal. Dr. Raman Goyal is a pioneer in bariatric surgery, specialist in India, who pioneered laparoscopy surgical practice in Mumbai, and also the member of the special board for NBE. He is also the editor of Pediatric Journal and has participated in a lot of talks. COVID-19 and its prognosis in obese and hyperglycemic patients as well. He is the immediate past president for IAGS. Welcome to the program, sir. Sir, any words from your end?
Thank you, Dr. Darshika. So I think Dr. Priti has been very clear in her message. And that is what is most interesting about obesity. The people who know about obesity, who treat obesity, find it very simple to manage because there are no fad diets, no magic bullets. These are day-to-day affairs that need to be improved at individual level, at family level, and at societal level. And generally, if that is done, the results are there, as she has shown in so many of our patients. The challenge is when the generally patients accept this, the challenge is whether the family accepts the change that is required, because the child is a part of the family, and it's very difficult to tell. I remember a boy who came to us, about 17-year-old boy, who came and we have for a bariatric surgery, and he was significantly overweight, about 180 kgs. And we had a detailed discussion, and his parents were sitting next to him. And then when the consultation was done, the father decided which restaurant they are going to eat. And the son said, "This is the biggest problem. I am ready to change, but my father loves eating out, and we eat out so frequently. And this is not going to..." He said that he knew where the problem area is. So we need to realize the children are intelligent, they understand, but many times they are helpless because they are in an environment which is not of their making. So I do agree with most of the things, and I'll briefly talk about what is the role of bariatric surgery in children and adolescent. When we talk of children, we are also talking of adolescent. And I'll quickly show a few slides to you.
Sure, sir.
Yeah. So, Dr. Darshika, are you able to see this?
Yes, sir.
Yeah. So, bariatric surgery in children, why and when? And this is an important question because every time a child who requires bariatric surgery comes to us, parents are extremely concerned because they feel that the child is a child, and why should he be offered surgery? Why this cannot be managed? And at what age surgery should be done? And that's an important question. So I operate in these places in Mumbai. So friends, as Dr. Priti has shown, that there is an epidemic of pediatric obesity. We all know that large number of people are gaining weight, especially in pediatric age group. We also need to realize when there is epidemic, there are always severe cases. Like in COVID, if 85% of COVID patients can recover, there are always certain number of cases, 5% cases, who may not recover. Similarly, in obesity, in pediatric obesity, there are children who are of severe variety, and they are the ones where we can help. So what is this is American data, and this is almost similar to what we see in metro cities in India, that almost 30 to 32% of the children are overweight. This is a survey also done in Delhi by Dr. Anup Mishra in affluent schools. About 17% of children are obese. That means they are more than 95 percentile. And 4% of them are above 99 percentile, or what we call as extreme obesity. Now, 4% may look a small number, but if you look at the large population or the pediatric population of the country, it's a number which will run in lakhs of children. And these are the children where we offer bariatric surgery as a primary mode of treatment, because the other options do not help these children to a substantial level. So the majority of these children, almost, let's say 96% of them, will not require any intervention, but 4% of them may require a bariatric surgery. Now, when we talk of, sorry. Dr. Darshika, are you able to see the slides? Yeah. Okay. So now when we talk of 99 percentile, it looks that this will mean a very high BMI. But please remember, these children are also shorter in height. So even at a lower weight, their BMI is high. So look at this, a child of 13 years, even if there is a boy, at 32.6 BMI, he is above 99 percentile. That means this boy qualifies for a bariatric surgery at a much lower weight than an adult and lower BMI. And similarly, for a girl, the BMI is slightly high. And at 17 years, a boy, even at 34.4 BMI, or let's say 35 BMI, qualifies for a bariatric surgery because he falls in 99 percentile compared to a girl who is 40 BMI. So it's very important to have this kind of clarity in mind, that 99 percentile doesn't mean that we are talking of 60 BMI. We are talking of much lower BMI because these are the people who have lower height, lesser height. Now, what about the comorbidities? Now we are talking of this subset of patients who are 99 percentile or more. Now, in these, because below this, Dr. Priti has already shown what is the average diabetes in average population, average pediatric obese population. But those who are 99 percentile, 93% of them are hyperinsulinemic. That means either they are pre-diabetic or diabetic. 67% of them already have sleep apnea. 36% of them hypertension. 13% of them have type 2 diabetes. And likewise, important thing to realize is 95% of them have 2 or more comorbidities. This is an important thing to realize because it's not about just lowering the weight. It's also about realizing that this child has adult disease at a young age and they are going to end up with complications of these adult diseases. Now, in most of the pediatric obesity or adolescent obesity, we have a family history. So 78% of them will have a maternal history of obesity, 60% will have paternal history, and 54% will have a sibling history. That means a brother or sister is also overweight. And these are all published data in pediatrics. So this is very important that there is a history of, there is an inheritance of obesity which is running in the family. Now, it is not only about disease. Obesity in children or adolescent is predictive of less education, especially less advanced education, higher rates of poverty, lower employability, and lower rates of marriage. And this is I have experienced it myself, that I was asked to operate on a young girl of 13 years in Bangalore, almost about 12 years back. And this girl was not attending schools for last 2 years because there was so much, embarrassment for her to go to school. Her batchmates, her friends, her teachers, everybody would tease her. And this stigma is a much bigger issue than the health issue for the child, because the child doesn't realize that how sleep apnea is going to affect him or her, but the child is embarrassed when her best friend or his best friend makes a comment on her. And this is because the diagnosis of obesity is written on the body, unlike any other disease, and thus they are visible in a group and they are stigmatized even before the health issues settle in. So friends, adolescent obese is a special patient because he is not the only patient. The entire family is affected and is probably equally sick or equally responsible. And I think Dr. Priti had been very emphatic about that today, and that has made my job easy. For significant weight loss, it's important in any bariatric or any obesity program that we identify and change the contributing environment, not identifying only what is wrong with this child, but what is wrong around him, where he gets access to the wrong foods. Is the parent not being a role model by exercising or not exercising? And it's seen that almost 65 to 90% of mothers who are seeking weight loss for their children are themselves obese. So when we look at a person who is presenting to us, look beyond, look at their parents, look at the siblings, identify the environment, and try to treat the environment and not only the person who is being presented to you for weight loss. Why intervention is required at such a young age? Because these children are having adult diseases at young age. There may be a 9-year-old girl with type 2 diabetes and uncontrolled diabetes. And it is known that 90% of these severely obese children will become morbidly obese adults. So it is not that with the age, the obesity will disappear or they will outgrow their obesity. 90% of them will become morbidly obese adults, and that is a matter of concern. Now, we know that lifestyle changes are the foundation of treatment of obesity. But in these severe obese children, 99 percentile and above, there is a study which was published where they had children from 24 families with a mean BMI of 34 and weight just 79 kgs. Now, when you say just, but please realize this was 188% of the ideal body weight. So it was significantly higher. And these children were given weekly behavioral intervention, 12 sessions every week, one session. And they realized 33% of them dropped out or did not complete the session. And overall, those who completed these sessions, they lost around 2.5 kgs. And out of this, all of them regained weight within 7 months of discontinuation of session. So lifestyle changes in severely obese have limited role to play. And that is why we think of, now this study, this is from Cincinnati Children's Hospital in US, where they analyzed data of those whose BMI was below 40 in children and those whose BMI was above 40. And they found that those who are above 40 BMI, only 6% of them completed their lifestyle treatment compared to 84% who were below 40 BMI. And similarly, the reduction in their excess weight was only 2% compared to 10% who were below 40 BMI. So this subset of patients who are above 99 percentile or above a certain BMI are a different group of patients because they are dealing with a severe obesity. And for them, the treatment options are the same. The sleeve gastrectomy and gastric bypass that we offer to adults, the treatment options are not different. And what happens? This is again published data about bariatric pediatric surgery, that those whose BMI was between 40 to 50, they had a 35% reduction in BMI. So if their BMI was 40, they probably lost about 12 BMI points and came down to about 27, 28 BMI. While those whose BMI were more than 50, they lost almost 40% BMI points after bariatric surgery, and which is substantial compared to lifestyle measures. And it is not only that. There are a lot of health outcomes which are seen. So as far as blood pressure is concerned, we found these 3 studies where the resolution rate was between 50 to 100% depending on the study. Sleep apnea, we saw 2 studies where resolution rate in both the studies were 100%. Type 2 diabetes was seen in this study in resolution in 10 out of 11 patients. That means all these 10 patients had HbA1c below 6.5 without medicine. And there was a significant psychosocial improvement, just like that girl I operated in Bangalore who could start going to school within 6 months after losing about 50 kgs. So these are very important outcomes. As far as maintenance of these results are concerned, surgical outcomes are at par with the results seen in adults with bariatric surgery. So they actually in children and young adults, I have seen the results are much better because they have many other reasons to lose weight. The peer pressure, peer comparison, marriage, traveling, partying, going out for education to other countries. They have many reasons, and they are physically more active in terms of going to gym and all. There is increasing data on successful outcomes of adolescent bariatric surgery, but the important part is that these children need a dedicated support system. And we have operated on some of the patients of Dr. Phatale from Aurangabad, and we have found that they are able to support our patients after bariatric surgery. So this is very important, that family is the first support system in India, and then we have physicians and then bariatric surgeons to provide this. Friends, recently, October 2020, bariatric surgery has been accepted by all insurance companies. So almost 80% of our patients we are operating in last 1 year during COVID times are all done on cashless basis. Most large corporates cover it for their employees, and the CGHS, central government employees and their dependents, do get complete reimbursement from central government. Thank you so much, Doc Plexus, for this invitation and for conducting these programs. We are accessible anytime if any physician wants any help about any of their patients or want any clarification about the discussion today. So thank you so much. If there are any questions, Dr. Darshika, I'll be happy to take.
Thank you so much, sir, for putting down the facts so straight here. We have one question from Dr. Nadia, who says, you did talk about the support system and the long-term follow-up that is required for any dealing with any child, like obese child. So what is the role of each member in the multidisciplinary team that manages an obese child?
Okay, I think that's $1 million question. I think let's not divide it between each member. Every member should have ownership of the program, and every member should have ownership of the patient. Because patient doesn't know, especially the child doesn't know whose help he has to seek. The child comes back to the program or to a physician with some symptoms. And it is the job of the program to identify whether psychologist is going to talk to the child, whether nutritionist is going to talk to the child, whether they need a help of an endocrinologist to manage some, say, new symptoms that are coming up, or a patient may be developing hypothyroidism, or patient may be overcorrected, patient may be taking thyroid medication, but as the weight loss goes down, weight loss happens, the thyroid medicine requirement may slightly go down. And so a team comprises basically, besides the surgeon, a physician, a nutritionist, a psychologist, a coordinator who moves the patient between different team members, endocrinologist, and a chest physician. And based on the symptoms, we move. It's not necessary that patient goes to every one of them. It will be like a harassment but if you have somebody who is very dedicated about managing pediatric obesity, it's a great asset, because then they know exactly because the children are either shy or they're ignorant about what problem they are facing. And I think Dr. Priti will be able to talk more about it, because she deals with children more frequently, because we do pediatric surgery, and but the numbers are not that great, but she deals in the obesity. Dr. Priti, what do you have to say about this kind of question about management of various problems of a child?
First and foremost, that every child should be regarded as a responsible adult. We should have first enrollment conversations. This is the thing. And as a Canadian Medicine Association, Obesity Association used to say that 5 A's are very must. First, ask whether the child really wants the weight loss, or are they enforced by the parents, because once they are not enrolled in that mission for the weight loss and how the greater health in futures, they won't do anything in spite of all the multidisciplinary approach also. So that's a very important thing one should address, that childhood obesity is though responsibility of the children, but it is of the whole family also, and the child should be treated as a responsible adult and showing the future of disease-free life. That is very important. And always we should be acknowledged and appreciate for smaller efforts also, because we know that losing weight, it is not an easy job. Not easy job. So many of the times parents use us to stand on the weighing machine every day. I strictly discourage that practices, because obesity itself is an important factor for the nervousness and depressions. And every day, if you ask the child to stand on the weighing machine, the child will be land up with more frustration rather than the actions. So some of the practices should be followed at family level, as well as at the multidisciplinary approach.
Thank you so much, ma'am. Sir, you did mention about how a child comes to a physician first, and then they are, of course, referred further. So with challenges like autonomy, informed consent, assessing the best interest of children and adolescents, how should a surgeon decide whether a child needs surgery or not?
I think Dr. Priti has already answered that. It's very important that we get child on board. Many times it happens that parents have expectations beyond the capacity of the child or beyond what is necessary. So we face situations in Mumbai where somebody brings their daughter because daughter can start modeling and they want the daughter to lose weight. And the daughter is very happy in her skin. She is not worried about 5 kg extra here or 20 kg extra there. She is enjoying her life. And that's why it's important to clarify this, that this is a major decision. I'm talking of bariatric surgery. It's a major decision. You take your time, you decide, because this is going to change the way you eat and live with your friends forever. And what I have found, Dr. Darshika, is that the children today come very well informed. I mean, even if parents remotely mention a word bariatric, they will Google search it.
Correct.
They read and they come prepared. And they ask questions which even parents do not know what to ask. And then in good number of children, the child says, I want surgery I'll decide after 2 years. I don't want now. And we should be able to ready to tell the parents that if you force your child to have surgery and child doesn't follow your instructions or doesn't follow my instructions, and if child has a problem in long run, he will blame the parents and he will blame the doctor forever. And it is better that he, even though what you are saying is being not an adult, consent is a problem, but getting them on board is as important, even if they are 13-year-old or 15-year-old, because they all understand what they are going to go into if we are transparent about what we are doing. If we are trying to hide things that we are going to do, then the child may be misled. But in a program where if people are openly discussing about what are the long-term results, what are the outcomes, what are the difficult areas, generally child gets the message loud and clear. And consent is not a big issue. If you are talking openly, consent is not a document that we sign. Consent is what we talk, what we interact. Consent is a dynamic process. And I don't bother much about, obviously document is indeed signed, but it's more about how we interact with the family in the consulting room. That helps always. It's very rare that we have a situation where the child feels that he has been misled or he has been trapped in a situation that he did not want. Dr. Priti, you want to add something? It's an important issue for family physicians also.
Yeah. Actually, as you rightly said, that whenever the severity of obesity increases, no doubt there are limitations for the physical activity also, hampering the day-to-day activity also. And especially whenever there is a strong family history of diabetes, hypertension, heart problems, and there are more chances the adolescents will develop at this young age. So one should think for the bariatric surgery, taking the risk-benefit ratio in particular situations, in particular patients also. So if they are at a high risk candidate for developing all the metabolic diseases at the young age, one should go ahead for the bariatric surgery. One should have their own doubts will be properly cleared by the pediatric surgeons. And as you rightly said, that children should not feel that they are being forced for the bariatric surgery.
Absolutely.
Yeah. And as you rightly said, we are having also patient post-bariatric, and they are doing wonderful jobs in their academic also, in their social interactions also. So that's the thing, one should take a call.
Sir, since you did mention about how big of a decision it is for even a child to sort of go through a surgery like that, how important is it the need of psychological monitoring before and after the bariatric surgery, especially with adolescents who are vulnerable to psychological conditions like depression and anxiety?
Yeah, I think extremely important. And the challenge is that neither the parents nor the child wants to go to a psychologist. The psychology is branded as a psychiatric disease in the country. And so what we have gradually done is that we have integrated psychologists in the program, and the parents are neither going to a psychologist, and every team member is part of the counseling team. So they talk to the family, they keep a positive thing, because what has been seen, Dr. Darshika, is post-operative depression is more of a problem than in terms of weight loss or weight regain. So we are very conscious of this, and keeping a positive frame of mind after surgery is important, especially in terms of a child, to ensure better results. I mean, probably the gatekeeper of a bariatric program is a psychologist. If he keeps the patient in the right frame of mind, the results are excellent. And almost over 21 years, every team member of mine has become a 70% psychologists themselves, because we have been dealing with these issues on a day-to-day basis, and we know where to push the child, where to help them, and it's a challenge all the time. It's an ongoing challenge what you just raised.
Thank you so much, sir. Those are all the questions from my end. We have Dr. Sundaraj and Dr. Maria. If it's open, if you guys have any questions, we can take that up. Dr. Sundaraj?
Okay, I have a question for Dr. Priti. Dr. Priti, same question. How do you manage psychological issues of the children in your practice? I mean, you have your own standalone obesity clinic in Aurangabad. I have the pleasure of visiting it sometime. And you have a very busy practice. So how do the children cope up, or how do you cope up with those children?
Basically, first and foremost thing is that we have to identify the barriers in going for the weight loss management in children, and make them aware about the realistic goals for the weight management. Many of the time, once they thought that they have to go for the weight loss, they should think if I am overweight by 20-30 kg, I have to lose all that 20-30 kg. That's not the thing. First and foremost thing, counseling part is that even modest weight loss, 5-10%, will definitely help them out properly. And another thing is that for the mental boosting, we used to have that interactive session after the counseling with our team. I am having counselor, I am having nutritionist, I am a physician, I am having endocrinologist also. So they can open up for the discussions. What are their barriers, or what are they think that what are the things they may come up in the way for their weight loss. So that's the big issue. And many of the times children used to think that they have to go for the weight loss means they will keep hungry, giving the reduced amount of food. And we used to counsel on that properly. They should get a proper amount of food that will fulfill their satiety. That's the big apprehension many of the obese children used to have that. So that's the thing we can address from each and every aspects of their barriers, what are coming in way of managing the obesity.
Excellent.
Yeah.
Very
Okay.
rightly said by Dr. Priti. So on this regard, we have a patient, Dr. Arsh, who would like to share his experience on bariatric surgery. Can we have his video, please?
Hey guys, my name is Arsh. I was 160 kgs back in the day in 2013 when I did the surgery. So my family had a problem of obesity. My dad underwent the surgery, my sister underwent the surgery, and after a year or something, I underwent the surgery. So my surgery was done by Mr. Raman Goel, Dr. Raman Goel. So as you know that my entire family has gone through it, and I did really have a choice when I was 160 kgs. So yeah, and it's been a wonderful journey since then, because I am literally half of what I was. So it's just a beautiful feeling if you compare it to back in the day and now.
So, Arsh, can you tell me what kind of weight loss expectation does a patient have with these kind of surgeries?
So in my opinion, I think the harder you stretch, the better results you will get, because at the point my father had lost around 60-70 kgs. He was in the 120s. My sister had lost around 60-70 more kgs, and I had lost around 80 kgs. So I don't think there's any specific bandwidth about how many kgs can you lose, but it depends upon you how much ever you want to lose. I think if you can attain what you want, I think that's how that much you can that is achievable, is what I feel.
Okay. Another question for you is, what are the major lifestyle changes that one has to make for better results?
First of all, you'll have to follow whatever the doctors say, because back in the day, when in 2013 I was 19 or 20 years old. So I was a college kid back then. So whatever follows that. So that's intense. It's like a lot of drinking, a lot of smoking, a lot of doing random things that you wouldn't do, and to hide all of that, to get assimilated in the crowd, you end up doing things that you are supposed or not supposed to do. So for example, if you want to be amongst people who you want to connect with, or go out partying, or so that's one thing that you need to change after the surgery, because you're not allowed to drink or smoke for roughly smoke, I guess, 3 months odd, or drink, I guess it's eight a year or two out. So those are the major lifestyle changes that you need to do, and one needs to know that that is going to affect their life if you don't adhere to those restrictions. So that is, and it was very nice for Dr. Raman Goel to tell me whatever changes that I had to go through, because he understood me about however I function, and he told me to it's for the betterment, and your life will change, and it certainly did. He's one gem of a person, dude. So I don't have I if there's anything which happens to me or my family, he's just a call away. He's always there, to be it at 12 in the night or 6 in the morning. He's just a call away, and he's one of the greatest persons I've ever seen till date. So I was an active kid. I played a lot of cricket. I played a lot of sport in my school days, but going to college, I did not end up playing that much because of my weight. So I after the surgery, I was able to do pretty much everything after 6 months. The initial weight loss was really quick. So I was down by around 20-25 kgs in the first year, which gave me an immense boost of doing whatever I wanted. I eventually ended up being one of the major leaders in my college festival right after a year out or a couple of years out in college. So lifestyle changes wise, whatever I am, I think whatever I am today, I think I'm because of that surgery which happened, and it certainly changed my life for various reasons of gaining confidence. Right from gaining confidence to doing this, I don't think if I was 160 odd kgs, I don't think I would be alive if I continued in the same lifestyle. But whatever I'm doing right now, I think I give everything to the surgery that I had gone through.
I think thank you to Arsh for sharing his experience so well. Any closing statements, Dr. Raman Goyal or Dr.
Yeah.
Priti? Yeah.
So, Dr. Darshika, basically, when a young person like him comes to the consultation room, many times it happens that first thing is they refuse to come for consultation. They want to get surgery done, they want to get a weight loss done, but they don't want to meet the doctor because they don't want their weight to be known. The second thing it happens, and it's very unusual, is that many of them would not stand on a weighing scale because they keep weight to themselves. Not even their parents are supposed to know their weight because they feel embarrassed that their parents. And so if you convince the parents to leave the consulting room, take their weight, they will forbid you from telling the parents how much is the weight. So there are layers and layers of issues in these patients. And it's a very interesting thing very satisfying thing for a surgeon like me, who never looked on the medical side so much. And obesity gave me an opportunity to interact with patients more closely than as a surgeon that I do. So I think Arsh and his family had been great because they all did very well in terms of weight loss, following the instructions. And I seriously believe childhood obesity is a major crisis brewing in our country. People do not realize the seriousness of it because when these children will become adults, they are already becoming adults, there'll be explosion of adult diseases that will come because these people were not cared for at an early age by the family or by the society. So I think this particular session is very close to my heart because I believe something serious needs to be done by all. Seriously, something has to be done by doctors, by society, and by government to take care of children. Because if the rate at which this obesity is increasing is allowed to continue, we are going to have a major problem on healthcare side, maybe within 10 years' time. So that's from me. Dr. Priti, your closing comments, and then we thank you so much.
Actually, I want to ask you regarding how to motivate the morbidly obese adolescent to reach the bariatric surgeon. Many of the time, there are barriers in reaching to the bariatric surgeon. Always parents used to say, once you utter the word surgery, parents used to say that कि हम सब कुछ करने के लिए तैयार है लेकिन हमको ऑपरेशन नहीं चाहिए. So in such cases, how we can motivate to reach the family to the bariatric surgeon. And another suggestion is that, as you rightly said, that the childhood obesity is becoming day by day. It is an worrisome things because till the date we are all geared up to manage the undernutrition. But now our government policies and all these things are not yet geared up to manage the malnutrition because of the overnutrition. So as we all doctors can have this platform to enroll our government to declare obesity as a disease, because unless and until obesity is not been declared as a disease, even not the family, not the society is very serious about the consequences of obesity. That's the suggestions I want to give this on this platform. And these are my closing remarks also.
Yeah, thank you, Dr. Priti. So I think as far as obesity being declared as a disease, WHO does recognize it as a disease. Indian government has never declared any disease as a disease. Typically I don't remember government declaring appendicitis as a problem or gallstone as a problem. So I think we go by WHO. Obesity is an acknowledged disease, and the very fact that central government in 2013 has decided that bariatric surgery will be covered under central government health scheme shows that government is well aware of it, that bariatric surgery, one thing is that obesity is a disease. Severe obesity needs severe major intervention, and they were paying for their employees and for their dependent families. In 2019, the Insurance Regulatory Development Authority India went ahead and said that bariatric surgery must be covered by all insurance companies. And from 1st October 2020, bariatric surgery is completely covered by all insurance companies. Nobody can deny a claim. And this is the only intervention which is reimbursed by the insurance for obesity treatment. They don't reimburse your gym membership. They don't reimburse your weight loss farms membership, but they pay for bariatric surgery now. So I think awareness is gradually coming. I don't foresee government coming forward because it's a politically sensitive issue. When there are so many people who are undernourished, how can government say that you do it? But it is moving in the right direction gradually. And, we have worked together in RO when I was the president and later. So as far as convincing the patient to go for surgery, I think it's a big challenge. It's as big as a challenge as sending a person to go for a psychologist or a psychiatric for a consultation. And I really admire physicians who still are able to send patients for surgery, because it's really a difficult task. The only way one can do it is by putting weight, the risk and benefit, and to tell them that the surgery has become as safe as a gallbladder surgery or a hernia surgery today. There is enough data to say that the mortality rates are very low. So I think more interaction, and saying that there is no harm in having a consultation. And now COVID has shown that we can do virtual consultation. I was, digitally a handicapped person till COVID came, and now I can teach people how digital platforms work. So I think a digital consultation a virtual consultation where it costs nothing to the family, is just about 20 minutes of togetherness, and they get experience and knowledge. And then Google Guru obviously is the ultimate which is able to show. So I think it's a combination of everything. There is no easy answers to your first question, but certainly we are going in that direction. Dr. Darshika.
Thank you so much, sir. I think I would, on behalf of Docplexus, I would like to thank Dr. Priti and you for this insightful experience sharing on such a pressing issue in the country about dual burden of malnutrition and obesity in children. We are lucky to have experts like you who support such discussions on national platforms. I would also like to thank Dr. Arsh for his time and agreeing to share his experience on our platform. I think it's a very big deal for a child or an adolescent to come up and accept and share his experience on such issues. Absolutely. Also, for our great viewing doctors, we are very thankful for your time and questions, making this event a huge success every single time. Please log in on Docplexus for your daily dose of medical updates. We shall see you next Thursday, same time, for another interesting session on CMS. Thank you and happy Docplexing. Have a great evening, sir. Thank you so much, ma'am.
Thank you, Dr.
Thank you.